So we have two great speakers lined up today. Our first speaker is Dr. Daniel Smith. So Dr. Daniel Smith is the clinical director of cystic fibrosis and bronchiectasis care and chair of the CF research group at the Prince Charles Hospital in Brisbane. His research interests include understanding the immunological drivers of exacerbations of bronchiectasis and the factors that promote the persistence of Pseudomonas aeruginosa lung infections. So a very warm welcome to Dr. Smith, and thank you for joining us today. If you would like to share your screen and get started when you're ready.
Excellent, thank you. Yes, thank you once again for the opportunity to talk at this seminar today. I'm going to talk about the new therapies coming through in the drug development pipelines for patients with bronchiectasis. So bronchiectasis is really the end manifestation of a number of different diseases that result in permanent dilatation, distortion of the airways. This encompasses a whole host of precipitating conditions, including genetic disorders, infectious insults, allergic conditions, and immune disorders and mechanical disruption of the lung. But once the lung has been insulted by one of these initial insults, this drives it towards a state of self-perpetuating tissue injury. So we get structural distortion of the lung, which leads to impaired mucociliary clearance, persistent infection with bacteria and viral infections, and then chronic inflammation. This is initially described as a vicious cycle model, but this has evolved into a multi-dimensional concept of the vicious vortex, which reflects the interconnected and amplifying nature of bronchiectasis pathophysiology, with each component being able to influence the other. For example, chronic infection not only drives inflammation, but it also alters the airway microbiome, which in turn affects mucociliary function and immune responses. So when we consider bronchiectasis pathophysiology in this nature, we can see that an approach that deals with one of these elements of the vortex is unlikely to turn off the disease. So we need to think about our treatments for bronchiectasis in disrupting all of these arms. We can look for techniques of improving mucociliary clearance, and there are already established therapies to tackle this, including a good evidence base for physiotherapy and effective airway clearance, and the use of hyperosmolar mucolytic agents to increase sputum rheology. We can treat infection, and again, there's clear evidence that treating exacerbations early and aggressively prevents lung damage and prevents disease progression over time. And there's reasonable evidence base to support the eradication of specific pathogens when they occur. For example, NTM and Pseudomonas aeruginosa, which are strongly linked with worse symptom burden and disease progression over time. And if first isolated, most people will embark on eradication therapy for the bacteria. There was 3 studies examining the role of macrolides in the early 2010s, the BLESS, BAT, and EMBRACE study, which all demonstrated clinical effectiveness in macrolides treatments, reducing exacerbation frequency and improving symptomatology in patients who are already having frequent pulmonary exacerbations. And again, these are fairly well established, although not licensed therapies for people with frequent pulmonary exacerbations. And to understand the approach to treating the airway inflammation in bronchiectasis, it's good to have an understanding of how that inflammation is being driven. And in most people with bronchiectasis, airway inflammation is neutrophilic. Neutrophils begin their life in the bone marrow and undergo a maturation process before entering the circulation. During this maturation process, they develop cytoplasmic granules, which contain the key serine proteinases, including neutrophil elastase, proteinase, and capsin G. These are activated during the maturation of the neutrophil by dipeptidyl peptidase 1, or capsaicin C. Circulating neutrophils then migrate to the site of infection or inflammation, where they release their active proteases to degrade pathogens and modulate the immune response. In the ideal world, the neutrophils would migrate to the lung, kill the pathogens, and then die by apoptosis, leading to resolution of inflammation. However, unfortunately, neutrophilic ills in bronchiectasis, apoptosis is dysregulated, and most die by apoptosis, which we die by necrosis, which then precipitates and perpetuates the inflammatory response in the airway. Neutrophil elastase is one of these key serine proteinases that is responsible for neutrophilic damage to the airways and perpetuating inflammation. And we've developed well-validated assays now to measure neutrophil elastase in airway secretions. We can see that neutrophil elastase correlates with disease severity and symptomatology, as well as the risk of exacerbations. So if too much neutrophilic inflammation is a bad thing, causing damage to the lungs, suppressing it should in theory be a good thing, but we need to be careful how we do that. If we turn off too much of the neutrophilic inflammation, then clearly we run the risk of developing overwhelming pulmonary infections and pneumonias. These two early studies looking at attempts at modulating neutrophilic inflammation targeted neutrophil chemotaxis. The CXCR2 antagonist study was performed in bronchiectasis, and while it reduced neutrophilic inflammation, there was no evidence of benefit. And although the adverse effects were not significantly different between the treatment and placebo arms, a greater number of people did drop out of the treatment arm due to symptoms. LTB4 is another chemoattractant for neutrophils. This study in cystic fibrosis patients again attempt to block this pathway, and unfortunately, this study was stopped prematurely due to an increased rate of exacerbations and an association with reduced lung function. This then leads us onto the greatest advance in bronchiectasis care in recent years, which is the development of the DPP-1 inhibitors. So these block that key protease that activates the serine proteases during neutrophil maturation. This is the first study, phase 2 study to publish the results of blocking DPP-1 action with a drug called brensocatib. This study involved 256 participants into three treatment arms of 2 doses of brensocatib versus placebo, and treated for chronic sputum producers who'd had 2 pulmonary exacerbations in the last 12 months. The primary outcome measures were all met, which was the drug was clearly shown to decrease time to first exacerbation, reduce the number of exacerbations, and as an exploratory endpoint, they also measured neutrophil elastase and were able to demonstrate a significant reduction in neutrophil elastase in patients on active treatment, which is consistent with the mode of action of the drug being suppression of neutrophil inflammation. The positive results from this phase 2 study led on to the phase 3 Aspen study, which again recruited patients across both treatment arms, studied in phase 2, as neither arm has been shown to be superior in that earlier study. Recruited a larger number of patients and followed patients up for a longer period of time over a 1 year period. Again, this supported the results of the phase 2 study, demonstrating a reduction in the exacerbation frequency and time to first exacerbation. Again, also demonstrated improvements in symptom scores, and again demonstrated the reduction in neutrophil elastase. The drug was very well tolerated overall in the study without significant greater adverse effects than placebo arm. There was an important exclusion criteria with these drugs, though, for a rare genetic condition called Papillon-Lefèvre syndrome, which is a congenital, an autosomal recessive absence of DPP-1, which is associated with plantar palmar hyperkeratosis. However, there was no adverse skin findings in the patients in this study. So the success of this phase 3 study has led to just last month, the FDA approving bronchiectasis as the first licensed treatment for intervention in people with bronchiectasis. On the heel of the study, the success of bronchiectasis, there are now other DPP-1 inhibitors in clinical trial development. This is a second results of a second study, but of a molecule produced by Boehringer Ingelheim. The phase 2 results again mirror those that we saw in the Willow and Aspen studies for bronchiectasis, with reductions in pulmonary exacerbations in response to treatment. The positive results from this phase 2 data has led to the development of a phase 3 study of this new molecule, which will be commencing around the world in the last quarter of this year. It was indeed just opened at our hospital this week to try and increase the use of these medications. This study will broaden the inclusion criteria to also include patients with cystic fibrosis related bronchiectasis and people with hypergammaglobulinemia that were excluded from earlier studies. The next method of addressing airway inflammation, which is being explored currently in clinical trials, is that of supplementing immunoglobulins. Immunoglobulins are a critical component of the response to infections, and we know that people with systemic immunodeficiencies are more susceptible to pulmonary infections and the development of bronchiectasis. And despite the intense neutrophilic inflammation present in the airways, proteomic studies have actually suggested there's a reduced level of local immunoglobulins within the lungs. In this phase 1 clinical trial, the attempt was to replace local immunoglobulin with a nebulized form of immunoglobulin. This was phase 1 study dosing over 14 days in people with bronchiectasis with a recognized airway pathogen, including people with Pseudomonas aeruginosa and the other common bacterial pathogens seen in bronchiectasis. There's 24 patients recruited into this study, so relatively small, and they were split across 2 dosing arms and 1 placebo arm. And as this was just a proof of concept study, they were really focusing on safety, and their primary endpoint in terms of response was really looking at change in bacterial load in the airway, and they managed to demonstrate at both doses of immunoglobulin therapy a significant reduction in bacterial load. Although, interestingly, there was also a kind of placebo response as well, and the bacterial load was reduced down in those taking the placebo drug also. They looked at a few exploratory secondary endpoints and demonstrated some improvement in quality of life scores by day 14, which was sustained out to 21 days, so for a week after the completion of using the medication. This pilot data is clearly encouraging, and there's now startup activities for a phase 2 study to explore this molecule further. We move on to strategies to treat infection in the airways more effectively. There's been a raft of studies over the last decade looking at different inhaled antibiotics. And overall, these studies individually have had variable results. You'll see on the slide the results from the phase 3 studies of Astrianan, ciprofloxacin, and colistin. While each demonstrated some improvement in either quality of life or exacerbation rates, this was not followed up in the paired study. So, for example, for AirBX, improved quality of life only improved in study 2, but not study 1. And they did not demonstrate any change in exacerbations. Equally for the inhaled Astrianan, 14% of patients discontinued the study drug due to side effects. Similarly, primary outcome was measured for the Respire study was only made in Respire 1 and not Respire 2. And in the Orbit series of studies looking at liposomal ciprofloxacin, exacerbation outcome was only demonstrated to be improved in one of the 4 studies, in study 4. And the PROMISE series of studies were looking at the role of improvements in with colistin, and although PROMISE 1 demonstrated a reduction in annual exacerbation rates, unfortunately PROMISE 2 was prematurely discontinued due to the impacts of the COVID-19 pandemic. Certainly the studies of inhaled tobramycin, either as a dry powdered inhaler or as an inhalation solution, have again demonstrated variable results, but generally demonstrated good tolerability. However, if you take the results of all of these different trials of different inhaled agent antibiotics and combine them with the other trials that are available for inhaled antibiotics, as has been done in this exact meta-analysis, there does overall seem to be a message that inhaled antibiotics are associated with reduced exacerbation frequency and improved quality of life, suggesting they do have a role in management. The question remains with these medications, though, is how they are best used. Many of these trials that I've just mentioned used a cyclical on and off routine of treatment, whereas there's some evidence that continuous nebulization of antibiotic is preferential to prevent the wearing off effect. However, this becomes a very burdensome treatment for the patients to use. Other ways of being explored to treat pulmonary infection include the use of bacteriophages. So bacteriophages aren't new, but they are being kind of rediscovered and reinvestigated in the last few years. These are viral molecules that attempt to disrupt the reproductive mechanisms within bacteria and result in their death. The Tailwind phase 2 study explored the role of a PaO2, so the most common lab strain of Pseudomonas aeruginosa. A bacteriophage to target PaO2 was given by nebulization to patients versus placebo, and they did demonstrate on their headline results reduction in bacterial quantities, but it was difficult to differentiate from the results available so far how much this differed from the placebo effect seen in those who were not given drug. And larger studies of these are awaited. There are also studies that I'm sure Andrew will refer to later that look at the role of using bacteriophages to treat NTM infections. Finally, looking at novel ways of dealing with infection, Remubermab is an anti-pseudomonal antibody. So this is an antibody, monoclonal antibody, which targets the PCRV molecule, which is a structural component of the secretory system of Pseudomonas aeruginosa. So this is a system that allows it to infect and damage host cells. And it also binds to the PSL exopolysaccharide, which is a key component of the biofilm forming capacity of Pseudomonas aeruginosa. The idea is that this molecule binds to these two target sites, disrupts its function and its ability to evade host cells, but also opsonizes it for more effective killing by the host immune system. The results of the GREAT 2 study, which looked at 2 different dosing frequencies of intravenous Remubermab against placebo, have already been so far published in abstract form, but they have shown early promise in reducing Pseudomonas aeruginosa colony-forming units in sputum, with some improvement in quality of life and prolongation of time to next exacerbation. And here we see those reductions in the Pseudomonas quantity, which was the primary endpoint. The study was generally well tolerated, and as we mentioned, there was improvements in their quality of life and reduction in exacerbation frequency. There's less studies at the moment looking at agents that improve mucociliary clearance, but the one agent that is worth mentioning is that of Arena-1. This is a nebulized bicarbonate buffered form of ascorbic acid and glutathione combined. Now, ascorbic acid and glutathione are both recognized antioxidant drugs, and they have a synergistic effect to boost each other's antioxidant effects at the level of the lung. The CLIMB-2 trial was a phase 2 study that used nebulized ascorbic acid and glutathione in people with chronic sputum producers for 28 days. Again, we're awaiting the publication of the results of this study. The headline reports suggested improved symptoms, reduced airway mucus viscosity, and reductions in neutrophil elastase. So these raft of studies coming through, as I've described, looking at different elements of treatment and different treatment strategies. And as we develop these drugs over the future, we need to consider how we develop them. This slide demonstrates where the patients from the ASPEN-3 trial of brensocatib were recruited from around the world. And on the left-hand side of the slide, the results from pooling data registry data from around the world on the etiology of bronchiectasis. And this paper also looked at the microbiology around the world and the symptomatology of bronchiectasis around the world, and showed massive geographical variations in disease from one place to another. The difficulty is clearly to recruit to these studies. The clinical trials are performed around the world, and the pooled results are reported. Whereas these treatment response may be very different in one region compared to another. And it's important to try and tease this out in later subgroup analyses. Equally, all of the studies I presented, all the major phase 3 studies I presented today, really used frequent exacerbations as a key inclusion criteria for participation. However, this recent publication from Lancet Respiratory Medicine last month has suggested that symptom burden is an equally strong predictor of future pulmonary exacerbations as prior exacerbation frequency, which suggests that we could look at broadening our inclusion criteria for clinical trials to include people who've got high symptom burden, regardless of their exacerbation frequency. In this study, they went on to retrospectively review the results of the symptom scores and quality of life measures in the 3 macrolide studies, and were able to demonstrate that in those patients, in those studies, that quality of life again was a predictor of macrolide response. And finally, in our consideration is, although we've talked heavily about neutrophilic inflammation in today's talk, there are some patients where inflammation in the lung is actually driven by eosinophilic inflammation. This is one study out of Italy, which has suggested a rate of up to 27% of patients with bronchiectasis have airway eosinophilic as opposed to neutrophilic inflammation, and suggested in comparison to those with neutrophilic inflammation, the eosinophilic group had poorer lung function, higher severity scores, and increased exacerbation rates. There has been one study looking at the possible benefit of benralizumab to tackle eosinophilic inflammation in bronchiectasis, but unfortunately this study was prematurely discontinued during the COVID-19 pandemic. So when we're designing our clinical trials of the future, we need to determine where the patients are coming from, the etiology of their disease, and the nature of their airway inflammation, and really try to phenotype patients into studies so we don't miss a treatment response signal to drugs and don't give up on medications prematurely. Thanks for your time this afternoon listening to my lecture. I'd just like to refer everyone to this excellent review of the state of the art of bronchiectasis therapies published in the European Respiratory Journal last year. Thank you.
Thank you, Daniel. That was a great summary of new therapies. We are running just a few minutes behind, but we'll see if there's any questions from the audience. Just raise a hand if there's a question for Dr. Smith. I might just start with, so in regards to brensocatib, I hope I've pronounced that correctly, is is access to that, in Australia mainly still clinical trial based? Like, when do you see it sort of becoming more prime time in clinical care?
Yeah, I mean, that's always the issue with these medications. They only received FDA approval last month in the US, so it hasn't gone to any other licensing authorities outside of the US yet. So it's not been to the TJ in Australia. And usually the way these pipelines are set up, it will probably be a couple of years before it's available in Australia. And that's where the utility of the ongoing clinical trials, such as the activity study of the BI molecule mentioned, which are lots of centres around Australia are participating in. So recruiting patients into those studies was really the only method of getting access to, or 50-50 toss of getting access to an active medication currently.
Yeah. Okay. Great. And I guess, I kind of draw some similarities with Trikafta for CF patients, and I'm, assuming that we may see similar sort of reduction in sputum productivity in these sort of patients with brensocatib, but like, I guess in terms of like our NTM patients and assessing sputum culture conversion, do you think it will have a similar impact in making that more difficult?
But I mean, my gut feeling is probably less of an impact. Certainly, when you look at the clinical differences that Trikafta made in the cystic fibrosis population in terms of reducing their sputum purulent and production, these drugs probably have a lesser effect than that. It's very difficult now, though, because active NTM infections was an exclusion criteria for all the brensocatib studies, and it remains an exclusion criteria for the BI molecule studies going forward.
Okay, interesting. All right. Well, thank you again. I can't see that there's anybody with hands up, so we might just keep moving.